Hello, everyone. Thank you so much for joining us today on our first segment of our advocacy series. My name is Allison Mallinger. I recently just started with Women of Reform Judaism. I am the new Advocacy and Communications Associate. I just graduated from Indiana University with a degree in journalism and political and civic engagement. So I'm very happy to join WRJ, especially working with these advocacy efforts. So back in January, the WRJ Women Act started with the advocacy plan. So with these webinars, we'll be discussing some of the high priority issues that include within those advocacy plan. Those issues include pay equity to women's health, violence against women, Israel, immigration reform, economic justice, and anything else that may come up in the future. So with that, this particular webinar will be focusing on women's health as our main advocacy issue, and in looking towards next week and the start of October, a very important aspect of women's health is breast cancer awareness. So, and as October is Breast Cancer Awareness Month, we'll be focusing on programming that local sisterhoods can participate in at the local level, and then bringing it towards the federal level, looking at women's health policy and what is going on right now in the public sector. So we have Melissa Rosen, who is the Director of National Outreach for Shasheret organization. She has worked in the nonprofit sector for over 25 years, and she herself is a cancer survivor, so she is particularly passionate about advocacy programming with Shasheret. We also have Sarah Christopherson, who is responsible for the leading legislative and advocacy efforts for the National Women's Health Network. She also directs the federal policy initiatives for Raising Women's Voices organization. She has previously worked in Congress for over 10 years, and she has a focus on the Affordable Care Act, Medicaid, Medicare, reproductive health, and income inequality. Thank you very much to Melissa and Sarah for joining us today. So from there, we're going to start with Melissa, and she can just discuss her role within Shasheret.
Perfect. We can start with the first slide. First of all, I want to thank you all for having me here. I'm very excited to talk about the work Shasheret does and some of the ways that work can impact you and your communities. We can move right to the next slide. And I want to take a moment to introduce Shasheret to you. Shasheret is a national nonprofit organization. We're the only organization that is addressing genetic mutations, breast and ovarian cancer within the Jewish community specifically. There are a lot of great organizations out there, but Shasheret really has a very unique view. We are represented in all 50 states, and we've been around for about 17 years. I think the best way to think about Shasheret is we have two main departments, two main goals. The first is our outreach and education department. I work with synagogues, with community organizations, with healthcare organizations to raise awareness and to educate our community about our heightened risk, which I'll talk about briefly in a couple of minutes, and how we can manage that risk, mitigate it, things like that. Our other department is our clinical department. We provide support both before, during, and after a diagnosis, regardless of a person's relationship to Judaism. And we do that through 12 national programs. Before I even talk about the programs, I just really want to reiterate that everything Shasheret does in terms of support is 100% confidential, 100% individualized. We find what works for each caller that reaches out for support, and 100% free. We keep the barrier very low so that anyone who needs support of any kind can come to us and receive. A couple examples of the programs that we have are an amazing peer support program that not only connects women based on stage of life and exact diagnosis, but also relationship to Judaism, so that a person who you're receiving support from in terms of peer support really understands who you are from the very start. We have a program for caregivers, whether that be a spouse, a parent, an adult child, a best friend. We have a program for women living with advanced or metastatic disease, a genetics program, a program specifically for ovarian cancer, a program called Best Face Forward, which helps women combat the physical side effects, the cosmetic side effects of treatment. We have an amazing program called Busy Box, which helps families that are facing cancer while raising young children. And we have a program called Thriving Again. That's our survivorship program. It's this amazing kit that helps women move forward from a diagnosis, both physically and emotionally. Okay, let's move to the next slide. You know what? I should have told you to move. I'm sorry. One more slide. Okay, so I think one of the things I want to take a moment to talk about is, why is this a Jewish issue? Why, when there are so many issues that women of Reform Judaism could be addressing today, that we decided to dive into breast cancer? So there are really two answers to why this is a Jewish issue. On the right side of your screen, or the left side, on one side of your screen, we talk about Jewish values. Really, it's visiting the sick, tikkun olam, taking care of one another. So important in Judaism, not just to celebrate the good times, but to assist people through the difficult ones. And so we talk about communal resources. And you know, the interesting thing about communal resources is this. From a medical perspective, there have been numerous studies that show that patients who have their non-medical needs met have better medical outcomes. So the support you provide as a sisterhood, as a temple, as a Jewish community to those facing difficult times actually impacts their outcome. People get through chemotherapy with less complications. They survive more frequently and for longer periods of time. It really impacts and is so important. And then the second issue on the other side is, of course, genetics. So interestingly enough, in the general population, 1 out of every 500 people, men and women, carry what is known as a BRCA mutation. If you carry that mutation, it raises your risk, your lifetime risk of being diagnosed with breast cancer to up to 88%, and ovarian for up to 45%. So in the general community, again, 1 in 500. In Jews of Ashkenazi descent, 1 in 40. That is a huge difference. And so we really need to educate our community differently than the general population is educated. So for instance, when the government or American Cancer Society makes a newsworthy decision, women should start getting mammograms at 40, at 50, at 45, whatever it changes very frequently, unfortunately. We can't agree. We get calls at Sharsheret of people panicking. They said now 50, but I haven't started and I'm 55. And we always say to those people who call, you have to remember you didn't read the fine print, which is for women of average risk. But women who are of Ashkenazi descent are not of average risk. And it really has more to do with figuring out your family history and your own medical history, and with your doctor coming up with a plan. So let's move forward and talk about one other thing. If you could change the slide. So, and that's the role of the rabbi here. As long as we're talking about community and this being a Jewish issue, let's talk about why the rabbi should be involved, because we're going to spend a lot of time talking about how sisterhoods can be involved and things like that. But I want to take a moment. Even though most rabbis have limited medical knowledge, again, it goes back to non-medical needs being met. And when somebody is diagnosed with a life-altering disease like cancer, very often they look for meaning, and that means that they are looking perhaps for spiritual guidance, whether it's wanting to become more connected to God or community, whether all of a sudden, a person's been very involved with the temple and they're angry and they shut off that relationship. There are a lot of things a rabbi can do. So we tell women who call us, consider your clergy. If your clergy are important to you, consider them part of your team, because they will make a huge difference. Now, when Women of Reform Judaism contacted me, they asked me to speak a lot about an initiative called Sharsheret Pink Shabbat. So if you can move, there you go. So Sharsheret Pink Shabbat is a national educational initiative that takes place, again, across the country, throughout all movements of Judaism. And its goals are really to raise awareness about risk and how to manage that risk, and about Sharsheret, because unfortunately, breast cancer, and to a lesser extent ovarian, are really rampant in our community, and I don't believe I've ever met an adult in a Jewish community that hasn't known somebody. So we want people to know that Sharsheret is there for them, and that you can refer women. You can let women know about us when you meet someone. I would say over the course of September and October and early November, we do about 200 of these programs across the country, but we do them throughout the year as well. We happen to kind of piggyback on Breast Cancer Awareness Month and Ovarian Cancer Awareness Month, which is actually September. But we do them year-round, and it's important for two reasons. One is women are diagnosed year-round, and this isn't a one-time only thing. We need to raise that awareness year-round. So that's really important, and sometimes October, doesn't work for a congregation, particularly with the high holidays falling smack dab in the middle of Ovarian and Breast Cancer Awareness Month. So if it doesn't work for you in October, think about but you find it meaningful, think about planning in a different way, for a different time. One of the most amazing things about this program is, just like we customize our support for all women, we customize the needs of a congregation to this program. So Sharsheret staff members will really help you determine what type of programming for your Pink Shabbat makes sense, what kind of resources you need, things like that. So in terms of different programs, some congregations keep it simple. They just have a rabbi speak from the bima. We have rabbinic talking points we share, and the rabbi speaks, maybe gives a sermon about it. Maybe they include a Misha Berach, specifically for those facing cancer. Sometimes a survivor will speak, and we train local survivors. Some congregations have a staff member for Sharsheret come speak. Very often, people do a pink-themed oneg or kiddush, or they'll have something we call pink tie attire. Sometimes the less serious things actually kind of get people excited to participate and wait, this is new, this looks different, what's going on, and really get people intrigued. And Sharsheret provides, like I said, we can help you we can help you with program development. We provide free educational resources and giveaways that you can share. And in terms of topics, some congregations keep it very general. Others want to dive into a more specific topic. And sometimes this happens if it's an annual event and you don't want to do the exact same thing every year. Specific topics could be genetics, could be being proactive about your health, could be how to become a more caring community, how to best support someone who's facing breast or ovarian cancer in your community. The interesting thing about that topic is, Sharsheret comes at it from a breast or ovarian cancer perspective, but what we found is, obviously, this is so relevant not only to other cancers, but anybody who's facing a difficult time, a different diagnosis, the loss of a loved one, the loss of a job, things like that, because a lot of that caregiving is universal. But what we've also learned is it's not obvious. People don't necessarily know how to do it. So it's been very interesting to be able to teach communities how to offer that support. Let's move forward one slide. So the interesting thing is we have a lot of communities, like I said, who run these amazing Sharsheret Pink Shabbats, but we have some communities that for a variety of reasons, they want to educate, but a Shabbat program isn't the right venue for them. Either it's a small community and they don't get a large crowd and they want to open it to the bigger community at large, so Shabbat doesn't work. Or sometimes, you know, a sisterhood already has a planned event, an annual meeting or something like that, and they want to do it. So there are a lot of other opportunities. One of the really popular ones, I'm going to move down to the third thing, is what we call a pink challah bake, where we get people together, and sometimes it's women only, sometimes it's co-ed, sometimes it's intergenerational, which is really nice. We come with pink, or people come and there's pink dough already there. We teach a fancy braid, and while the dough is rising, once it's been braided, there's a lot of information about health empowerment and women's health empowerment and the specific steps you can take to live healthier, from knowing your family's health history to not pushing off scheduled routine screenings and health appointments, to reducing stress, eating healthier, moving a little bit more, things like that. And then participants go home with this pink challah that's ready to bake the second they get home. And we say, this weekend, invite somebody to share a meal with you on Shabbat or not on Shabbat. And when somebody says, why is your challah pink? You can start spreading awareness yourself. A lot of communities do healthy living programs, whether it's a cooking demonstration or a walk around the community or, you know, family Zumba, things like that. Some communities are more suited to educational lectures, where somebody comes in, whether it's somebody from Sharsheret, a local oncologist, a local genetic counselor. Panels are very popular, where we have different expertise come and talk and really educate in a more in-depth way. Other communities have done book clubs where either Sharsheret provides interesting op-eds, or they pick a book that's related to this topic in some way, and we have suggestions, and then they talk about it. Or they'll do a manicure for the cure, where, and you know, either we've had communities where they bring in professional manicurists, but what's really fun is to get like the youth group involved and have the teens do it. It's not the most beautiful manicure, but they're nice, and it gets the teens educated about the same kind of health empowerment that we talk about. And then the last thing I wanted to mention was the beyond that you see listed there. We actually have a good number of synagogues that we call Sharsheret Supports Partners that do these type of programs on an annual basis, sometimes through the sisterhood, sometimes through a Bikur Cholim committee, those who visit the sick, or anything, you know, like that. And that's a really special partnership. We do ongoing education that some of our partners participate. We can come and speak without charging a speaker's fee, things like that. So if you're interested in that, that's something to definitely ask me about. Let's move forward to the next slide as we're getting ready to finish up this section. So just a couple of things I wanted you to think about. So Sharsheret provides free educational resources, and we provide ones that are very specific, but we also provide some general educational ones. What's Jewish about breast cancer? Your Jewish genes. So is there a place in the temple that you can display our resources? Do you have a table that flyers are put on? Do you have a literature rack? Things like that. Are there any programmatic additions that you can make this year based on what you've learned today? You may already know someone who would benefit from our services, so please introduce them to us in terms of, you know, telling them to go on our website or give us a call, or you could share my email address, which I'll give to you. And then how can your temple become an even more caring community? I know this is such an emphasis in this community, and it's wonderful, but there's always something else to be done. Okay, let's go to the last slide. And these are the different ways you can connect with us. You see our phone number and our website. But I also want to give you my email address, which you'll forgive me, I really should have put up here. And it's simply mrosen, MROSEN, at sharsheret.org. And you can see how Sharsheret is spelled on the slide. I'm going to hang around for the entire webinar, and certainly you'll be able to ask me questions. That at the end. But if you are interested in doing some programming or didn't hear something you're interested in today, please give me a call, send me an email, and I would be happy to connect with you. Okay, Allison, I'm going to pass it back to you for the next section. And thank you very much.
Yes, thank you so much, Melissa. That was very informative, and it will definitely help our women.
Thank you.
Our next speaker is Sarah Christofferson, and she'll be talking about definitely the women's health policy end of this conversation.
Thank you both. And I'm thrilled to be with you guys, and particularly to tie in with breast cancer, because we're going to talk about the Affordable Care Act and Medicaid. I'll give you a little bit of an overview of what Congress has been working on this last few weeks about repeal efforts, and it really ties in with breast cancer awareness, because when we think about the gains that women made through the Affordable Care Act and the expansion of Medicaid in the last, since 2010, we're really talking about, do your cancer screenings and your mammograms and your annual well woman visits get covered without copay and deductible? And if you're diagnosed with cancer, are you guaranteed that your insurance will actually cover the prescription drugs, the hospital stays that you might need? Are you guaranteed that your insurance isn't going to get revoked the second that you get sick? And that you're not going to come up against an annual or a lifetime cap if you are diagnosed with breast cancer and you're getting treatment? And then, of course, if you're a breast cancer survivor, which is my mom, my grandma, my aunt, all of whom got breast cancer when they were younger than I am now, are you going to spend the rest of your life with a pre-existing condition that insurance companies can discriminate against you? So when I think about breast cancer and I think about the Affordable Care Act and health reform, they really tie in together, because we're really talking about how these policy changes at the federal level and the state level impact women's lives and their quality of lives and their financial security. So with that, I'm going to talk real quickly, if we can go to the next slide. What is the Affordable Care Act? And you might be thinking, well, it's been 7 years. We think we know, we've got it. So I won't take too long on this, but I want to just quickly cover. So the ACA has kind of a two-track approach. Whenever I talk about it, I try to talk about this two-track approach. And the first one is it made insurance better for everybody. So sometimes people will come up to me and say, well, I don't have Obamacare. And I'll kind of whisper back, yes, you probably do, quote, have Obamacare, in the sense that there really was this goal of making insurance better for everyone. So whether you got, your health insurance through your employer, or whether you go out and buy it in the individual market, or whether you were eligible for some of the other expansions that we'll talk about, your coverage got better. So I've already touched on some of them. We got rid of the annual and lifetime caps. We got rid of prohibiting insurance companies from discriminating based on pre-existing conditions. So my mother is a cancer survivor, can go out and buy affordable coverage, and she won't be forever discriminated against because she had and survived breast cancer. And then particularly for women, in the pre-ACA days, just being a woman was a pre-existing condition. So the National Women's Law Center did this amazing study where they found that non-smoking women were being charged more, even for plans that didn't cover maternity care, than smoking men. Just being a woman was enough to get you a markup in how much you were paying in your premiums. So I've already mentioned cracking down on rescissions, this idea that, folks would be healthy, they'd have insurance that they thought covered them. The second they got sick, insurance companies would look for a reason to stop covering them, drop their plans. And then covering essential health benefits. So covering your prescriptions, covering mental health care, covering hospital care, covering maternity care. I have this little caveat here about large group plans. There's a slightly different standard, but the end result is the same, that your insurance has to be a high quality comprehensive product that actually does what you think it's supposed to. And then preventative care, free from copays or deductibles or additional costs. So you go in for that mammogram and it is covered. And so all of your preventative care, you don't have to worry about that going against your deductible or paying copay. And then, the plans up to age 26, many of you are familiar with. One, this very last one at the bottom, doesn't get talked about a lot, but it's really important. The requirement that insurance companies, large insurance companies, pay 85% of your premiums for actually providing health care. So, in the old days, premiums might go up and up and up and up. They're still going up, but they might go up and up, and you'd think, are they going up because the costs of providing care are rising, or because there's a fabulous CEO getaway where all the ice statues are, spewing champagne? Right now, there's a guarantee that insurance companies must put your premiums into actually providing your care. So this is the one track, making insurance better for everybody. The second track, if we go to the next slide, is covering people who didn't have access to insurance beforehand. So the ACA does this in two ways. The first way is it expands Medicaid to the poorest and most vulnerable. So original Medicaid, 1965, Lyndon B. Johnson Medicaid, we always think of as low income, but it actually left a huge gap. It's the low income and program. So you had to be low income and pregnant, low income and disabled, low income and elderly, low income and a child. For a whole lot of folks, low income working adults, they didn't have an option. They couldn't enroll in Medicaid in their state. That was it. So the ACA expanded it. So for low income working adults, you could, for the first time ever, get access to insurance. And get access to Medicaid. And because of the Supreme Court decision in 2012, the law had envisioned that everyone would expand Medicaid. Supreme Court said, no, it's going to be optional for states. Only 19 states have chosen not to expand. We'll talk a little bit more about that in a minute, but I wanted to flag that. And then the second way that the ACA helped expand coverage is for folks who were sort of low, middle, and moderate income. It helped them buy insurance, private insurance, in the individual market. So it subsidized premium costs so that even if premiums rose, millions of people could get access to, they wouldn't rise so much for them. They'd help get government help paying for it. And it also helped keep copays and deductibles low for lots of low and moderate income folks. So if you can imagine, your deductible maybe it's supposed to be $1,000, but under this program, your deductible would only be $200 to help improve insurance. So if we go to the next slide, this is kind of what the ACA looks like. On the left-hand side, you'll see the ACA as the way it was written and the way it is in 31 states. That blue triangle at the top, that's the subsidies to help people buy private insurance. It's more generous the less you make, it's less generous at the top. And we would argue, the National Men's Health Network would argue those subsidies should really be a lot more generous. They can actually, many more people could be helped if we were a little more generous. But still, that's kind of the current structure. And then the bottom, that blue square, you see the Medicaid expansion. And on the right-hand side, you'll see for those 19 states that haven't expanded, there's just a coverage gap. There are 3 million people in that blank white space who don't have access to affordable insurance, period, because of the choices that their state made, state choosing not to, participate in Obamacare, quote unquote. So that's kind of what the ACA looks like right now. What is Congress considering? So let's skip to the next slide. Congress this week, potentially as early as tomorrow, will be voting on their kind of last gasp package to repeal Obamacare. But they actually are going to go much, much, much further, way beyond just simply repealing the ACA. And they're going to attempt to rush through this massive package that would not only repeal the ACA, It would also really disrupt healthcare markets nationwide, and it would go after that original Medicaid, that 1965 Lyndon B. Johnson, been in place for 52 years Medicaid. And so, you know, I say it's the last kind of proposal out there. You may recall over the summer, there were multiple competing proposals. Some of them lined up in similar ways. Some of them had very different features. All of them got voted down in the Senate, you know, by razor-thin margins. There was sort of this collective sense of, okay, they couldn't repeal the Affordable Care Act on a party line basis. So now we're going to move to, you know, a bipartisan approach. But September 30th is the last day under their current kind of procedural rules that they can rush through a repeal with just Republican votes. They only need 50 senators. And since September 30th is the day that this kind of whole process turns back into a pumpkin, and they can't do it anymore, they're making one last big push. And they're kind of throwing every idea they've had over the summer into this one last package. So this first, you have heard, I'm sure you've heard them say, defund Planned Parenthood. I don't like to use the defund language. I think it confuses what's actually happening here. What's actually happening here is Congress telling women and men that they can no longer use Medicaid, their insurance, as a provider of their choice if that provider happens to be Planned Parenthood. So you might want to walk to your local Planned Parenthood and get a cancer screening, get STD testing, get contraception, get any number of health services. Right now, you walk in, you have Medicaid, you see a doctor, your doctor gets reimbursed by Medicaid. Under this Graham-Cassidy proposal, and actually all of the proposals Republicans have put forward, you wouldn't be able to do that anymore. So if Planned Parenthood is your local clinic and the next nearest community health center or hospital or doctor's office or clinic is 100 miles away, you're driving 100 miles just to use your health insurance. The next big thing that Graham-Cassidy does is the second bullet point, and it's huge. It eliminates the guarantee of coverage under both the ACA and Medicaid starting in 2020, so just 3 years from now. And what I mean by that is, if you qualify for the ACA based on your income, or you qualify for Medicaid based on your income, or you qualified for original Medicaid based on your income and, you know, you're pregnant, you're elderly, et cetera, you get it. You're eligible. You get it. You're entitled to it. Graham-Cassidy would change all of that. There would no longer be a guarantee of coverage. And they would cap the amount of funding that is given to each of these programs. And they would kind of eliminate all the requirements that states are required to live by. So you'll see this third bullet caps and cuts traditional Medicaid. So instead of the original program where the feds pay a percentage of the cost, and if the costs rise because, say, there's a hurricane that creates a major public health crisis, and so suddenly people become much more expensive than they might otherwise have been, or if there's a downturn, an economic recession, a lot of people lose their jobs, and so they now qualify. Under current law, the federal share of that increases. People get more help from the federal government. This would change all of that. And that's why I've got those question marks actually in the second bullet about who knows what's going to happen. So, you know, once the federal requirement to help is met, once that cap is met, federal aid cuts off and then states are on their own. And so how they're going to deal with these cuts and these caps is just simply by dropping coverage and dropping people. So under the bill, states are, you know, under current law, states are required to cover prescription drugs. They're required to cover pregnant women. They're required to cover disabled people. Graham-Cassidy basically gives them the flexibility to say, you need to manage costs. We're giving you a lot less money. You can manage costs by just dropping care. And that's what states are going to end up having to do. And then this very last bullet repeals the ACA. So it takes the amount of money that the federal government would spend on the Medicaid expansion and would spend on providing subsidies for purchasing private health insurance. Instead of doing that, it turns it into a much smaller pot of money and then gives it to the states and kind of says, do what you want with it. So if we can go forward for just 2 seconds and then come back. So go forward to the next slide. So you can see in this slide, there's my original graph with the blue triangle and the blue box. That's what the ACA looks like. Graham Cassidy says, let's take that same amount of money, cut it by over a third, turn it into a lot smaller amount of money, and redistribute it. And so now let's go back to the first chart, or go backwards one. So, yeah, sorry, go back. Yes, perfect. So when I say it's a no strings attached block grant, all of those things that we talked about earlier that the ACA did for women, states can have the option to just simply undo that, right? They've got enormous flexibility to just simply say, we're going to go back to the bad old days where you could discriminate against women and people with pre-existing conditions. You can go back to the old days where we'd treat rape and sexual assault as pre-existing conditions. And I've actually wrote a fairly lengthy piece in Rewire about a month ago, just talking about how rape and sexual assault really used to be and could once again, under these proposals, considered pre-existing conditions that would price women out of coverage. And then selling junk insurance. So, once again, that insurance that disappears the second you get sick, that doesn't actually cover your hospital stay or your breast exam or your prescription drugs. So that's what the Graham Cassidy would do for the next 6 years. Now let's go forward 2 slides. So past my orange slide. Starting in 2027, that money just simply disappears. It's just gone. So the money that right now we would spend to help people purchase private health insurance, or we'd help them get covered through Medicaid expansion, it just simply disappears. So basically states would have 7 years to come up with a replacement, or a few years to come up with a replacement that would only last for 7 years, and then it's all gone. If you listen to press reports, it seems like they don't have the vote. But I'll tell you, having, I worked for Congress when we passed the ACA. I have been through every repeal fight since, all the ups and downs this year. It is a zombie bill. I will never believe it's dead until, I'm afraid it might outlast me, these repeal efforts. And so while I have found it very encouraging that, a handful of Republicans have come out and said they oppose the bill, they have said, it's shameful that we might vote without a CBO scoring, knowing just how much premiums could rise under this bill, knowing how many people could lose insurance. Senator Collins had a very powerful statement, talks about, the many people who could be hurt by this bill. She cited the doctors, the American Medical Association, the American Hospital Association, even the insurance companies coming out and saying under this bill, people with pre-existing conditions would be harmed, millions of people would lose coverage, millions of women in particular would be hurt. So that's all very comforting, but I don't know that we can certainly not in the next few days, because again, they have this looming September 30th deadline. But anyone who kind of really cares about the coverage gains that women have made, we can't take it for granted. We can't stop. And we can't assume that they're not going to continue to look for ways to try again. But if this bill does fail, even then we're not done. So if we go to the next slide, what happens if this kind of most recent crazy bill fails? Well, the first bullet, they could go after healthcare again through a tax package. So I said they've got this special procedural rule that allows them to do it with just 50 senators. That expires on the 30th. But they want to create another rule like that. It's called reconciliation. You've probably heard it in the press. They want to create another reconciliation for taxes. And they could conceivably go after healthcare in that package too. So House Republicans had passed a budget outline or a blueprint through committee a couple of months ago that would make really, really deep Medicaid cuts in exchange for tax cuts. So you have these deep tax cuts and you pay for them with Medicaid cuts. So there's still a chance that even if we get September 30th, they joke at the office that I'm the storm cloud, so I apologize for that. But that they could still go after healthcare in a tax bill. But alternately, they could pass bipartisan legislation. And so there's this really promising effort with the Republican chairman of the Senate Health Committee and the Democratic ranking member of the Senate Health Committee to do kind of a market stabilization package. So it would be to actually fund some of the things that the Trump administration has started to cut off funding for. And so, there was this really positive effort going underway. When they decided to make one last push around repeal, that effort died. It was actually very clear that Senator Alexander was told by Republican leadership to stop. Let's see if we can get Graham Cassidy through. If we can't, maybe you can take up your bill again. So we're hoping that there's a role that Congress could do some positive, proactive steps in helping health insurance. But there's other terrible things. So the Trump administration is already actively trying to sabotage ACA enrollment. And you may have read about this in the press, that the open enrollment period, they cut it in half. That they are taking healthcare.gov, which is the site that most states use to sign up people for health insurance. They are shutting that down on a number of Sundays. So if you think about people who work and maybe don't have access to a computer at work, don't have access to a computer during the work week, might be looking to Saturdays and Sundays as a day in which they'd, take the time, get on their computer, go to the library, get on the computer there, do some research about which plan makes the most sense and sign up. Well, the administration is actively trying to block them from being able to do that on Sundays. And it's unprecedented, and there's not a legitimate reason behind it. They're claiming site maintenance, but there's absolutely no reason why they need to do site maintenance during these kind of high traffic days. And then they've also eliminated all of what they're called the navigator funding positions to help people sign up, because as you might imagine, if you've never had health insurance, if you're the first person in your family to have health insurance, the whole process can be very intimidating. Navigators really help you navigate that process and figure out, what plan would work for you. And you might have heard, crazy rumors about the plans or Obamacare, but, here's the truth, right? That's the role navigators play. It's really useful. The Trump administration has cut all that. And then we keep waiting any day now for the Trump administration to release a rule that would gut the contraceptive coverage. So I mentioned earlier that preventive care is covered without copay or deductible, and contraceptive falls into that category. So under a ruling from HHS and the Obama administration, it's sometimes called free birth control. It's not exactly free, but you don't pay a copay or a deductible. And so particularly if you want a high cost, really expensive type of birth control that also happens to be really effective, like an IUD or an implant, that can be prohibitively expensive, so expensive people couldn't pay for it out of pocket. And the Trump administration is expecting to release a rule. We've seen a draft of it that says more or less anybody with any employer with any kind of moral objection of any kind can just simply not cover birth control at all. Just simply doesn't have to cover birth control at all. And so, that would really, imagine if a Fortune 500 company decided, well, we have a moral objection, so, our millions of employees or hundreds of thousands of employees are no longer covered. So we're waiting for that. And then lastly, there's a whole lot of authority that the Centers for Medicare and Medicaid could use to make it just harder for people to get care. So, institute work requirements, which for women could be really, really harmful if you think about the fact that we are much more likely to serve as caretakers for older family members or younger family members. So they could do a lot of kind of terrible things. So if we go to the next slide, what can you do? It's, we have to keep fighting. We have to keep fighting for what we believe in, and we, as hard as it has been, to keep making phone calls to senators, keep making phone calls to House members, keep talking to friends and family members about what's at stake. I frankly feel a little exhausted, and yet we have seen what constituent and voter and public engagement can do, right? We can see that a lot of attacks have been made and have not been able to come through. They've certainly been blocked so far, knock on wood, in Congress because people have been calling their senators, people have been calling their House members, people have been going to town hall meetings, people have been writing letters to the editor to the local newspaper, people have been telling their personal stories. So, I talk about my mother as a breast cancer survivor. I talk about my son who has asthma, and that would be counting as a pre-existing condition. You know, I tell my story. What does the Affordable Care Act mean to me? What does healthcare mean to me? What are our goals for the future? Telling that story. And we can't let up, because the folks who would want to take away healthcare from us are not going to let up either. So with that, thank you so much, and I will turn it back to Allison.
Yes, thank you so much, Sarah. Just like Melissa, is very informative, and it helps us definitely look at the situation in real time, especially with the upcoming vote, possibly tomorrow. I'm now going to open up for any questions from any of the attendees. We did receive one question so far, specifically for Melissa, and it's from Julia Weinstein. It says, does Shosheret have printed materials that we can put up in our synagogues? So specifically for those programming resources.
Yeah, absolutely. We have educational pieces that can be up year-round. We have pieces that we'll send to you without cost to coordinate with a program. Like I said, it could be something about Jewish genetics. It could be what's Jewish about breast cancer. And then we have actually posters you can put in the stalls in the bathrooms, a little bit about genetics and knowing your family history. We also have some things that we tend to give just a couple of that are meant for people who've been diagnosed. So facing breast cancer as a Jewish woman, things like that. So we have plenty of educational resources, as well as giveaways that we send when there's a program. And all of this is free of charge. You just simply need to give me an email.
Thank you so much.
Sure.
I actually have a question for Sarah. So you were talking earlier about the different calls to action as you concluded. How do you think that these programming efforts with Shosheret help that call to action?
I think that's a great question. And I think, getting people talking about their health, getting them aware, so the statistic that for the general population, it might be 1 out of 500, but for, our community, it's 1 out of 40. And what does that mean? And how does that play into the bigger health system? And so, certainly having those conversations within a community about, okay, so if 1 out of 40 of us could be diagnosed, what policy options then are available, and how does that play into that bigger national conversation that's taking place? And, is there something that we as a community might want to do to influence what legislators are doing? Because they represent us, and they have they been hearing from us? And I think making the personal and the political overlap so that people understand how those two interact, I think is really important.
Absolutely. Thank you. To piggyback
Allison,
off.
Can I add to that?
Absolutely.
Can I add
Go
to
ahead.
that for a second? Sarah, what you said was right on, and I just want to take it one step further in terms of imagining how it might practically impact. So if obviously 1 in 8 women get breast cancer in their lifetime, whether they carry a mutation or not. But if you have a strong family history, you might actually be carrying a mutation. And if you do, there are preventative measures you can take to reduce your risk to close to nil to be diagnosed with breast or ovarian cancer. But being BRCA positive is a pre-existing condition, then you may choose not to get tested. And if you choose not to get tested, you have a very strong likelihood of being diagnosed. So it's a catch-22. You could prevent it or reduce your risk to very low, but then lose your health insurance, potentially. Or you could just wait for the cancer to hit, but know you'll be covered. So it's a very, very practical way to look at it.
Absolutely. To piggyback off of that, we just received a question. So why aren't voters from both parties not more upset about the loss of health care coverage?
I mean, so this is Sarah. I'll jump in and I'll say they're actually pretty upset. So when you look at the this proposal, the Graham Cassidy proposal, it's got something like 20% of people supporting it. Well, that means that not only do nearly all Democrats and nearly all independents oppose the bill, but huge swaths of self-described, Republican voters also oppose. And so pretty much every office, every Senate office that I've talked to, Democrat or Republican, has not heard hardly anything in support of this proposal, except for the most ardent group that just wants to repeal Obamacare, quote unquote. And even in that group, there's a lot of concern about going after original Medicaid, because like I say, all of these bills have gone so much further than just simply repealing the ACA. So I think we are hearing that, and the fact that there is such outrage. But, and I can only speak to what I read in the press. There is a very large push from the Republican donors to move forward with something. In fact, so there was someone quoted, a Dallas, wealthy man from Dallas, saying, the piggy bank is closed until they do healthcare repeal. So I think, we have to keep that public pressure up, because there's such intense pressure from this very vocal group of donors who want to see that repealed.
Absolutely. So just to reiterate what you're saying, this push is coming from the donors versus these personal stories at the local level.
Yes, and for this, I can only report what I read in the press. So what the New York Times has covered, what the Chicago Tribune has covered, what the Guardian has covered. But yes, that the momentum for this is coming from the kind of Republican donor group.
Absolutely. If there are any other questions. If not, thank you so much again to Melissa and Sarah for sharing your expertise on this very important topic. And thank you to all the participants as well. I hope you feel informed now on women's health policy. Please join us for our next webinar, which happens to be next week. Next week is a very important week in the advocacy realm. The next Supreme Court session starts. So our next webinar will be focusing on a SCOTUS roundup. So what particular cases are most important to us as Reform Jews, and that again align with these high priority issues within our advocacy plan. We'll have presenters Daniel Goldberg, who is the Advocacy Director for Alliance for Justice, and Barbara Weinstein, who is the Associate Director at the Religious Action Center. So we'll be discussing these particular cases and how it definitely affects us as Reform Jewish women. Unless that's it, unless there aren't any other questions, thank you so much and have a wonderful day.
Thank you very much.